Yes, good evening to one and all. This evening, we have the webinar on myeloproliferative neoplasms, and the lecture is entitled as MPNs in 2020, Incorporating New Options. And I'd like you to meet our faculty. We have Dr. Ruben Mesa from US as the chief speaker. We also have Lieutenant Colonel Uday from Delhi. He is going to present a case to be discussed by Dr. Ruben. This webinar comes to you from Mumbai Hematology Group. It is supported by Novartis and managed by Mice Ideas. I'm thankful to the team Novartis, especially Rajini, Abhijit, and Lekha VK, and also from Mice Ideas, Mr. Rajesh Sharma, Mr. Yash Agarwal, and Mr. Kalpesh, the Executive Committee of Mumbai Hematology Group for allowing us to do this, the faculty of today's webinar, and all of you for sparing a Saturday evening. Remember that you are most welcome to ask questions. Please put the questions in the question box right from the word go. And you have the feedback form also, which you are most welcome to fill up. And you are entitled to obtain the certificate of attendance. For any difficulties for any one of the MHG webinars, you can contact either me or Kalpesh at mbAgarwal1@gmail.com or kalpesh@miceideas.in. Let me have the pleasure of introducing our chief guest speaker. That's Dr. Ruben Mesa. He is MD, FACP, Professor of Medicine, Director, Mace Cancer Center, UT Health, San Antonio, MD Anderson Cancer Center, Mace Family Foundation, Distinguished University, Presidential Chair, San Antonio, Texas, US. He's an international expert on myeloproliferative neoplasms. He's involved in MPN research for the last 30 years. He led the development of NCCN panel guidelines, the first US guidelines on the diagnosis and treatment of myelofibrosis, polycythemia vera, and essential thrombocythemia. Dr. Mesa has been the principal investigator or co-principal investigator of over 80 clinical trials. He co-led the research team leading to the FDA's approval of ruxolitinib for both polycythemia vera and myelofibrosis. He is currently leading the investigations of several other drugs in the field of MPN. Dr. Mesa was elected to sit on the National Board of Directors for the Leukemia and Lymphoma Society, and he sits on the board of MPN Educational Foundation. After earning degrees in nuclear engineering and physiology with minors in radiation, biophysics, and bioengineering from the University of Illinois at Urbana-Champaign, Dr. Mesa received his medical degree from the Mayo Graduate School at the Mayo Clinic College of Medicine in Rochester, Minnesota. He completed his residency in internal medicine and his fellowship in hematology, medical oncology at Mayo. He is a fellow of American College of Physicians, is certified by the American Board of Internal Medicine in hematology and medical oncology. Well, thank you very much for allowing me to speak to you. And now I request Dr. Mesa to share his screen and give his lecture.
Wonderful. Well, first, my thanks for the kind invitation. It's wonderful to see Dr. Agarwal again, as well as participate with my friends from the Mumbai Hematology Group. I greatly enjoyed my visit there several years back. You guys always have wonderful meetings, are incredibly engaged and interested in the care of patients with heme malignancies. So it's really an honor to be with you today. Indeed, there are so many sad things that we must attribute to the COVID pandemic, but some positive things as well. And one of those is I think that we have been, even more connected globally than we have been before by all of these platforms. And I think our ability to both use them and leverage them to interact well has really increased dramatically. So look forward to getting a chance to interact with you all, and certainly in the future as well. Now, a lot of exciting things going on in the myeloproliferative neoplasms. Look forward to giving you some updates, in particular around polycythemia vera and myelofibrosis. We then have a very challenging case that our colleague from Delhi will be presenting, and certainly lots of chance to answer questions, as well as discuss some of the evolving information we're learning regarding MPNs, MPN patients who have been infected with COVID. So although I don't have any specific slides on that piece, there are a lot of things that are ongoing, a lot of things that we are learning, and happy to discuss that as well, of course. Now let me share my slides. Are you able to see those okay?
Yes, sir.
Excellent. All right. Here are my disclosures. One can say that I have many conflicts, or that more accurately, that I have been involved with most of the drugs that have been tested in MPNs. Well, let's start with polycythemia vera. Myelofibrosis, polycythemia vera, essential thrombocythemia, all clearly interlinked chronic myeloid neoplasms, and they clearly have a relationship with the broader set of myeloid neoplasia, with MDS, acute leukemia, etc. But they each have their own distinct phenotype as well as disease burden. And indeed, with polycythemia vera, we know this JAK2 V617F mutated driven disease leading to erythrocytosis, increased counts, has short-term burdens of symptoms, risk of thrombosis and bleeding, the potential of splenomegaly, and the potential of progression. So all different pieces. Now, our goals of therapy are really to try to make the disease as invisible in the life of the patient as possible, reducing symptom burden if present, clearly trying to prevent thrombotic or hemorrhagic events, hopefully with a minimum of toxicity for the patient. Now, our options certainly have included therapeutic phlebotomy, selective use of cytoreduction, now JAK inhibitors, as well as antithrombotic modalities. Now, as we try to manage these patients, I view that for all PV patients, we consider the use of low-dose aspirin. We consider the control of hematocrit strictly to 45 or less percent, sometimes with some slight modification if people live at very high altitude. Now, the utilization of cytoreductive therapy has been somewhat dependent upon the concept of risk. And in P. vera, the concept of risk is really associated with what is the risk of thrombotic or hemorrhagic complications, as opposed to prognosis of survival. As we get around to prognosis, that is more relevant in myelofibrosis, where the disease is more life-limiting. Now, there is low risk, younger, better control of the counts, no history of thrombosis. Higher risk, age over 60 or prior thrombotic event, and intermediate in between. Now, as we'll see, there's a variety of things evolving in terms of challenging the paradigm of intervention for only high-risk patients. Now, my colleague Aylu Teferi has been involved in developing many prognostic scores for MPNs. We had, when I was at Mayo Clinic, a very extensive database of patients from the past, and they've been able to find that some of the drivers in terms of survival included these features: the SRSF2 mutation, abnormal karyotype, older age, and higher leukocyte count. And as I share with my trainees, there's a lot of prognostic scores out there, and it's helpful to know they exist. It's helpful to know where to find them. Trying to memorize them all is not overly beneficial. But understanding, what are the biological clues that any prognostic score is telling us? Here, it's largely telling us features that are suggestive of disease that's much more likely to progress. So SRSF2 being older, abnormal karyotype, again, probably not a surprise to any of us, that again, all of this is probably slanting toward people with a higher risk of progression toward post-PV myelofibrosis, higher risk of progression to acute leukemia, more genomic instability. Now, how do we treat them? Well, I'm going to share some of our US-based guidelines. There's many international guidelines, British guidelines, European guidelines. I'm sure there are guidelines similarly for yourselves in India. And they're all similar to one another, but let me walk you through these as I was involved with the development of these. And again, it began with low-risk disease, monitoring for vascular events. Everyone gets hematocrit control to under 45. Everyone is on aspirin. And then we watch. And then here is really the crucial part. If they are asymptomatic and no indications for beginning cytoreductive therapy, then we continue following them. The gap I see in the United States, and I can't comment on the practices in India, is that I do see that there are individuals that likely would benefit from cytoreduction, but there's a delay in beginning it. So what are some of those changes that should take someone from being phlebotomy and aspirin only to also having cytoreduction? Well, clearly if they have a vascular event, clearly if they have bleeding, clearly if they continue to have a need for a lot of phlebotomy, especially if they don't tolerate phlebotomy well. If they're developing splenomegaly, leukocytosis, significant thrombocytosis, or probably the most common disease-related symptoms that really are not resolving with aspirin and phlebotomy. So the patient who should be on phlebotomy and aspirin is a patient who you have begun on this, who's low risk, but who feels very well and is otherwise stable. If not, they may benefit from cytoreductive therapy. I do think aspirin and phlebotomy alone probably should be in the minority of P-Vera patients. Now, what about higher risk disease? Well, again, here we're monitoring for thrombosis. Very important, we're trying to manage cardiovascular risk factors. Those are relevant. Control of cholesterol, hypertension, diabetes, or other drivers of cardiovascular risk. If they begin on medical therapy, the US guidelines still have hydroxyurea or pegylated interferon as those first line options. We'll talk about ropegylated interferon in a moment, an alternative formulation that has gotten an approval in Europe to be considered in frontline for P-Vera and are seeking that approval elsewhere. Now, I am involved with the MPN Research Consortium. This is funded by the National Cancer Institute in the United States. And we performed an international study looking at pegylated interferon versus hydroxyurea in high-risk ET and PV. And we found at a year that pegylated interferon was at least equivalent with hydroxyurea for control of the disease as related to vascular events and thrombotic events. Unfortunately, we were unable to, because the company no longer really wanted to develop the drug in this arena, did not support a much longer extension to see whether over a much longer period of time was pegylated interferon superior. It is hypothesized that pegylated interferon may be superior to hydroxyurea over the long term for a decreased risk of disease progression. There are hints in that regards as it relates to ropegylated interferon. Now, as we looked at these patients, again, particularly at the 24-month period, we did tend to see already at that point likely superior activity and control for the pegylated interferon arm versus hydroxyurea. I will say that I have used this extensively in my practice as an option, particularly for younger patients, for women of childbearing age who are planning to have children, and in those that have not received ruxolitinib, which would probably be my preferred second-line option in P-Vera, we'll consider pegylated interferon. Now, I mentioned this ropegylated interferon. The pegylation is different, and it's a pegylated interferon alpha 2B. It has been developed by Pharmacentia in Taiwan, as well as AOP in Europe. In India, I suspect it would be Pharmacentia. I suspect that would be the proponent. Heinz Gislinger in Austria had done a very nice study of comparing rho-pegylated interferon to hydroxyurea. And then they have updated us at ASH and EHA over the years with the continuation PV study, really looking at the longer term data. And it's really in the longer term data where we're starting to see evidence of superiority. There clearly has been non-inferiority for every trial that has compared these two modalities head to head. So over time, you'll see there the line in red, improvement in terms of complete hematologic response with the treatment arm with the rho-pegylated interferon, as well as over time, we see the better control of the allele burden. Let's look at the high-risk algorithm. So again, patients have begun, as I had mentioned, on hydroxyurea or pegylated interferon, and then we are monitoring for an adequate response. And it's here, again, where I find some of the gap in the United States, where individuals are on frontline therapy, but there is a delay in recognizing that they have had an inadequate response. So what does an inadequate response look like? Well, one, are they tolerating the therapy well? So toxicities with hydrea, ulcers, skin manifestations, skin cancers, hair loss, GI side effects, excess cytopenias, neutropenia in a sufficient dose to control the counts. Any number of those things can be a factor. Pegylated interferon has probably more toxicities that include autoimmune disease, thyroid dysfunction, malaise, flu-like symptoms. So again, are they tolerating the therapy? Have they had a new event? Clearly, we are using the medication to try to prevent vascular events. If they have a vascular event, they likely have had insufficient control. Are they still needing a lot of phlebotomies? If so, they're probably not having an adequate response. Are they having splenomegaly, thrombocytosis, leukocytosis that are not adequately controlled, or are they having significant disease-associated symptoms? So again, with P-Vera, again, the concept is have the disease be as invisible in the life of the patient as possible. Patients, if they are manifesting these are the individuals that really can benefit from ruxolitinib. In the US, in many areas, it's approved as a second-line therapy and can play a very important role in helping these individuals. Now, what is the data behind the use of ruxolitinib? Now that has been, we have much in the way of follow-up. So the approval study was a response study. There have been single-arm phase 2 studies in hydroxyurea failing patients that clearly showed a good activity of ruxolitinib in this group of patients. And again, as a JAK2 and 1 inhibitor in polycythemia vera, where the majority of patients, well over 90%, have the JAK2 mutation, it's been speculated from the very beginning that the drug would be, very active and helpful. We looked both at the initial study and now as well as at longer-term follow-up, comparing ruxolitinib to best available therapy in patients that had failed hydroxyurea. And what was seen is that there was a clearly superior control of hematocrit, clearly superior reduction of splenomegaly as a sign of more problematic disease, clearly improvement in symptoms compared to best available therapy, both in aggregate and individual symptoms. And of course, the control arm includes most of those things that we would pick otherwise: hydroxyurea, interferon, peptidobromin, etc. Over the longer term, we see that these responses are very durable, many patients remaining on the therapy with good control of the disease, becoming phlebotomy independent with significant improvement in terms of their disease-associated symptoms. And again, here showing long-term good control by complete hematologic response. So that including also achieving a platelet count of less than 400,000 and a white count control of less than 10,000. Now, there was a response 2 study that was done because the response study had required splenomegaly as an eligibility criteria. And it certainly was discussed, well, there are many patients that might benefit but don't have splenomegaly. Are the results just as applicable to them? And it was seen that indeed that was the case, that in the response 2 study, ruxolitinib was superior to best available therapy, and the response rates and the differences were very similar. So splenomegaly does not need to be present to consider ruxolitinib for these patients. However, if it is present, that makes the case even stronger in my eyes. We did see improvements in markers of iron deficiency. Again, one of our secondary goals is to control the disease so that they become phlebotomy independent and they don't have to have the abnormal state of being iron deficient. And that is beneficial. As someone who has studied symptoms in MPN patients for many years, iron deficiency certainly aggravates the underlying difficulties these patients face. So the improvement in iron deficiency is beneficial. Now, what toxicities can one expect? Again, you're very familiar with ruxolitinib from myelofibrosis, and overall a very well-tolerated drug. The dose-limiting toxicities are anemia and thrombocytopenia, which in myelofibrosis sometimes is an issue. In polycythemia vera, to some degree, we are looking to lower the red cells and the platelet count, so that rarely is a difficulty. I'd say the most genuine thing one needs to be mindful of is an increased risk of herpes zoster. Again, it is in the minority. You see there in the 4 to 6% range, but it can occur, and I do make patients both aware as well as starting antiviral therapy early in the rare chance that it does occur. Additionally, over time, there probably has been recognized a slight but a genuine increase in the risk of non-melanoma skin cancers. Again, difficult to dissect from their prior history of hydroxyurea, which increases that risk as well. But I do have patients, particularly older patients or patients that have a history of non-melanoma skin cancers, have a good skin exam either with myself or a dermatologist on a routine basis. Now, the benefit in terms of thrombotic events seems to suggest that there is a decrease in the rate of these events. The study was not powered for a decrease in events because the frequency of these events, fortunately, is relatively low. But mechanistically, we have good reason to believe these data. We believe, again, a decrease in inflammation and other aspects as beneficial to decreasing that risk of thrombosis. I mentioned the issue of safety, with again a slightly higher risk of non-melanoma skin cancers as the driver. Now let's pivot a bit toward myelofibrosis. Now, myelofibrosis shares some of the features of PV, but is a more serious disease for the majority. And how it affects people is really quite heterogeneous. There still can be risk of vascular events. So just having MF does not alleviate that concern, but it probably is a little lower than PV and ET. There is risk of progression to acute leukemia. And again, relevant as we end up discussing the case a little bit later today. There are the potential of cytopenias, anemia, thrombocytopenia, some transfusion dependent. Splenomegaly is a much more prevalent feature in MF than in PV. They clearly can have symptoms, and some symptoms are more problematic. Weight loss, night sweats, bone pain, fever, and spleen-associated symptoms. Both groups of patients can have fatigue, itching, headaches, or those difficulties. Now, an individual's baseline health is incredibly relevant in this discussion as well. If they are 75 years of age and have a history of congestive heart failure, having transfusion-dependent anemia is quite problematic. So the baseline health is really quite important. Now, our group has worked hard to better understand the symptom part of this equation and have worked to develop a series of questionnaires that now have become validated over time, looking at fatigue, spleen-related symptoms, constitutional symptoms, and quality of life, and developed the myelofibrosis symptom assessment forms. These have been published, and then the vascular or mood-related symptoms, and created both the MPN-10 and the MPN symptom assessment form. These have now been translated and validated in many languages and have been tested in many countries, including in India. Now, we've learned several lessons from these analysis over the years and questionnaire studies, including seeing the heterogeneity of the symptoms. So here is data in almost 2,000 patients in a heat map type presentation, with each line from top to bottom representing one patient. So there's 2,000 lines across, from blue to red being absent to highly present. And we're able to see that one, patients fall into 4 quartiles, and 2, you're able to see the more prevalent symptoms that are almost universal across the spectrum. Fatigue, issues of intimacy, which we largely find are really derivative from fatigue and other difficulties impacting that aspect of an individual's life. Now, we have also been able to find that symptoms cluster, and we believe that symptoms do have a link to the biology of the disease, related to inflammation, related to cytokines, related to aspects of the disease. They are not necessarily, however, superimposable for our prognostic risk scores. So the risk of a vascular event or your survival risk in myelofibrosis is not. Indeed, as we think of the most significant prognostic change, a shift or move toward acute leukemia, that we do not find is associated with a symptomatic worsening. Now, there has been much research regarding prognosis in myelofibrosis, in part because it has a very heterogeneous prognosis. Any one of us have experiences with patients with myelofibrosis who have life-threatening disease within a year or 2 versus others that have had the disease for 30 years. So in an effort to try to better understand that risk, as well as to better guide the selection of whom to consider for stem cell transplant, there have been many prognostic scores. This is the DIPSS Plus. Many of these created again by my colleagues at Mayo that have mined an extensive database in this process and found, again, you'll see both clinical features as well as other features such as karyotype in trying to separate risk from low to a high risk in terms of survival. The more recent scores have now incorporated the molecular phenotype, and our understanding of additional mutations continues to evolve. But in this, they found several mutations to be high risk: ASXL1, EZH2, SRSF2, IDH1 or 2. And again, combining these with the blood counts, blast, symptoms, being able to stratify people according to risk. Clinically, I think this is most helpful in terms of trying to assess a individual for stem cell transplantation. Now, these scores are incredibly complicated to calculate. Therefore, the website that you see listed here that was created, you were able to plug in these variables and get a score back. So that is very helpful to utilize when caring for these patients. Now, these prognostic scores are able to help give us a sense of survival, but they don't necessarily tell us who benefits from therapy. People have asked, well, should we be treating people with, quote, early myelofibrosis? And I ask them this question because what is early disease is in the eye of the beholder. Does that mean that they only have mild anemia, a hemoglobin of 11? Does that mean that they only have some symptoms or some splenomegaly or only some molecular markers? Or does it mean that they were more recently diagnosed? We do know that individuals all have a finite amount of time typically in each of the risk scores, and that it is a progressive disease as well as a disease that gives significant burden. I do think over time we likely will treat all patients with myelofibrosis. In that observation for this disease is probably inadequate, but there are likely still some that is reasonable. Again, if the disease is as neutral in your life as possible. Now, I show you all these prognostic scores, but it is important to realize that all of these are variables that are on a continuum, and that although we say a hemoglobin of less than 10 is the cutoff for a worse prognosis in myelofibrosis, it's pretty clear that individuals with a hemoglobin less than 12, but greater than 10, still probably do worse, or with splenomegaly, or with some hepatomegaly, or with a platelet count lower than normal, but higher than 100. So again, anything that is abnormal still probably is a sign of more difficult disease. Now, these new molecular scores are helpful in that they do help to refine what used to be some of our prognoses. So I know in India, as well as others, there's always much discussion regarding, testing of the molecular nature and in whom is that applicable and whom is that worth the additional expense or resources. I would say most importantly, those individuals that we're considering for the issue of stem cell transplantation. I don't think that it necessarily makes a big impact on deciding whether a patient who's symptomatic with splenomegaly benefits from JAK inhibition. I do think it matters if you are struggling with whether to proceed with a transplant with the, let's say, 55-year-old that might be a candidate. Now, how do we manage myelofibrosis? Well, we need an accurate diagnosis, whether that's primary or have they evolved from ET or PV into myelofibrosis. Again, an area where there's frequently a gap or delay. We assess the survival and the disease burden, and these two are complementary concepts. We develop our treatment plan. Does that mean that they're going to go for a stem cell transplant in the near future? Perhaps with a run-up of a JAK inhibitor like ruxolitinib for a few months before to optimize their performance status and spleen prior to therapy. We start with frontline medical management, with for most would be ruxolitinib. If they have progressed or have an inadequate response, do we move to a salvage transplant? Do we move to a second-line therapy? Or do we manage them according to an algorithm for advanced phase or blast phase? Now, ruxolitinib became our frontline medical therapy, and up through the fall of 2019 was the only approved therapy in the United States based on the COMFORT studies. Ruxolitinib versus placebo, I helped to lead this study along with my colleague Dr. Verstavchek, or ruxolitinib versus best available therapy. And these trials showed clear benefit in terms of improvement of splenomegaly and improvement of symptoms compared to best available therapy. In parallel, there have been subsequent studies that showed that the therapy was also efficacious in an equal degree with individuals with intermediate 1 risk disease. So at first we had looked at intermediate 2 and high risk disease, but now recognizing individuals with intermediate 1 risk disease similarly can benefit in terms of improvements in splenomegaly, improvements in symptoms, and likely longer-term control of the disease. Here's a slide from US treatment real-world experience, again showing benefit in individuals with lower risk myelofibrosis having similar benefit. There was experience from the JUMP study. Again, that was the expanded access study, and this similarly showed real-world experience with improvements in splenomegaly and symptoms for individuals receiving ruxolitinib. So the experience in the development with ruxolitinib has been very consistent, and all of these studies have again validated the initial observations of improvements in splenomegaly, symptoms, and likely disease control over time from lower risk to higher risk disease. So ruxolitinib has clearly become our cornerstone, and it is a very important therapy for our consideration. Now, that said, does everyone benefit indefinitely from ruxolitinib? We still do not have a curative medical therapy for myelofibrosis. So what is ruxolitinib failure? I would say it really depends on what the other options are. In the United States, in the absence of another good option, we likely will leave patients on ruxolitinib indefinitely. But key considerations as you have other options. The first option is, are they really having an adequate enough dose, or are you really managing the ruxolitinib to the optimal degree? Are they on enough of the medication to really benefit? Did you start at a lower dose and that dose needs to be increased because you started on it because of concerns of cytopenias? Evidence of failing in the response is progressive splenomegaly, particularly if they were stable for a long period of time and now that progressed. The spleen is growing if they have progressive symptoms. If they have complications, it depends. They had bleeding, cytopenias, etc. So I would try to manage them through complications and dose issues. And if they have clear signs of progression or clear evidence, particularly of a non-heme toxicity that I think is Rux-related, that is where I will consider change to an alternative agent or approach. Now, we do know that individuals that come off of ruxolitinib likely have a poor outcome, especially if they have evidence of clonal evolution. So if they have clonal evolution, that is particularly a period to be strongly thinking about more aggressive approaches in appropriate candidates like stem cell transplant, given the decrease in survival in this group. Now, there has been a consideration since the beginning whether a ruxolitinib holiday would be beneficial for these folks. From the laboratory of Ross Levine, it had been speculated that a ruxolitinib holiday could help to overcome some intrinsic disease resistance. And there has been data from the Cleveland Clinic demonstrating that some individuals can benefit from this. The ones I would suggest to really consider this in are individuals that clearly were benefiting, clearly had a plateau phase of benefit, and then now have evidence of splenomegaly and symptoms. To wean them, give them a clear ruxolitinib holiday of a few weeks, and then resume to try to regain the response. Now, there are other JAK inhibitors in the mix that are being developed. It includes pacritinib for lower risk, with individuals with low platelets, momelotinib for individuals with potentially with anemia. There have been many JAK inhibitors that have been tested over time that are no longer in development due to issues of toxicity. Now, one of the additional JAK inhibitors is now approved in the United States is the drug of fedratinib. I was involved with the development of this therapy, and fedratinib is a JAK2 and FLT3 inhibitor. It is an agent. That was used in both the Jakarta 1 and the Jakarta 2 study. We did an analysis that we presented at ASH in back last year, looking at individuals with moderate thrombocytopenia with a platelet count 50 to 100,000. This was fedratinib versus placebo, and we saw both spleen volume response rates and symptom response rates that were similar to those individuals with a higher platelet count, and that the toxicity seemed similar, so that it could potentially be considered in a full dose in that group. We looked and reported on issues on the health-related quality of life in these individuals, and again saw improvement by each symptom, and we saw that at each of the time points, showing the symptomatic benefit for these individuals, as well as an impact on the quality of life as assessed by the EQ-5D. We did update our second-line data. This is a trial led by Claire Harrison that she and I designed in people who had failed ruxolitinib. We did an updated analysis using more stringent criteria of what it meant to fail ruxolitinib for these individuals, and saw a, let's say, 30-ish response rate in terms of formal spleen response and symptom response with these individuals. So fedratinib is now approved in the US, and they are seeking that similar approval elsewhere. In the US, it is approved in either the frontline or second line setting. However, I think due to individuals' prescribing physicians' comfort, it is used primarily in the second line setting in myelofibrosis, given their experiences. Now, pacritinib is in a global trial now to try to become approved. It has been safely used in individuals without a lower platelet cutoff, and is specifically being looked at in individuals with a very severe thrombocytopenia. There have been many trials done. I've led a couple of these studies, and now we've found that probably twice-a-day dosing of the medication is likely superior to using Rux in this group of individuals with severe thrombocytopenia. Momelotinib had a frontline study comparing to Rux, looking for a frontline indication, and showed non-inferiority in terms of improvement in splenomegaly. It did show some inferiority in terms of symptom control, and therefore did not meet the trial primary endpoints, and did seem to have some benefit in terms of cytopenias. This trial is, there's now a new trial ongoing, the Momentum trial, in individuals with symptomatic myelofibrosis who are transfusion dependent, who have failed ruxolitinib. So looking for that second line indication. Now, there are other things we can bring into the mix when caring for our patients with myelofibrosis. For anemia, there's other drugs that can be helpful: ESA, steroids, danazol, thalidomide, lenalidomide, and potentially luspatercept in the future. For symptomatic splenomegaly, we obviously have ruxolitinib as our cornerstone. We will rarely consider splenectomy these days. Any of you that have had your patients have a splenectomy, it's a tough therapy to undergo. There are a lot of complications. There's a lot of thrombotic events. We tend to really consider it in a small minority that have failed more than one JAK inhibitor. If individuals had extramedullary hematopoiesis, these are not common things to occur, but they can. They can act as a mass. We've seen people with cord compression. We've seen people with lung masses. We've seen people with, it can pop up almost anywhere, but it's not common. But if it does, it is very sensitive to radiation therapy. Now, there are a robust set of drugs in the pipeline looking at activity in myelofibrosis. And I'm going to just cover a couple of these for you. But as someone who cares for these patients, I'm deeply excited that there is this degree of interest. And part of it is that none of these things exist in a vacuum. Therapies that help myelofibrosis might help many myeloid diseases or others. JAK inhibitors have other potential areas of benefit. Ruxolitinib has been shown in early trials to have intriguing activity against the inflammation of COVID-19 induced pneumonia, and currently has a phase 3 trial ongoing with goals of getting individuals off ventilator support earlier. This has nothing to do with MPNs. This is just COVID-infected patients based on the anti-inflammatory properties. So again, even though I show you a pipeline of JAK inhibitor therapies, JAK inhibition may have a variety of different health benefits. We know the approval of ruxolitinib in graft versus host disease. So again, there's a range of reasons that these drugs are important, both in myelofibrosis, but certainly beyond. But in addition to that, as a target, cell cycle checkpoint inhibition is certainly being looked at. Telomerase inhibition with imetelstat, aurora kinase inhibition with alisertib or other drugs, anti-fibrosing drugs, the SL401, now approved for BPCDN, signaling tyrosine kinase inhibitors, including the hedgehog inhibitor approved for acute leukemia, Glastigib. There are the MDM2 inhibitors from Kartos or Roche. There's navitoclax from AbbVie, immunomodulation, histone deacetylase inhibition, LSD1 inhibition with IMG 7289, BET inhibition. So again, a very robust and interesting pipeline. Now, clearly trying to improve for the situation. I'd mentioned that anemia is clearly a challenge with these folks. ESAs can be helpful if an individual has an inadequate erythropoietin response. Luspatercept has been approved in the US for anemia in hemoglobinopathy, specifically beta thalassemia, and now in myelodysplastic syndrome. There is clearly activity in myelofibrosis, both alone or as an add-on with individuals with ruxolitinib, and might become both approved and an option for folks in the near future. The BET inhibitor from Constellation Pharmaceuticals, CPI 0610, has created a great interest. It, again, having an impact on the cells as well as helping to decrease some of the pro-inflammatory cytokines, may have greater activity in those individuals that have the ASXL1 mutation. They have done a series of studies looking at it as either monotherapy in ruxolitinib failure or as an add-on to individuals that have an inadequate response to ruxolitinib. And clearly are seeing activity in terms of improvements in splenomegaly or symptoms in those as an add-on. Additionally, here showing the benefits in individuals both transfusion dependent and non-transfusion dependent. These data are early, the numbers are smaller, with larger randomized studies planned and being launched. They are also looking at it as an add-on therapy in JAK inhibitor naive patients with ruxolitinib from the get-go. Now, these results are early, but do suggest that the combination might be more active than ruxolitinib alone. Now, as you might imagine, this might make for a very expensive approach with two therapies. So I think we will learn more over time regarding what is that delta of one drug versus two, and in which patients is that likely to be the most beneficial to justify that expense. Adverse events with this drug, again, are around cytopenias or GI-related side effects. Now, an additional add-on approach from the BCL2 inhibitor navitoclax from AbbVie, again showing a nice spleen response rate in these individuals that were already on a baseline ruxolitinib. So adding the second drug did seem to really kick up the responses, as well as improvement in disease-associated symptoms and a better control of the white count. I suspect that we'll have much more of this sort of approach in the future, whereas opposed to saying there's been a ruxolitinib failure, let's just completely switch to a different agent. I think it's likely to be more likely to add another drug in to preserve some of the benefits of JAK inhibition while trying to gain some benefit of an additional agent. Here showing some of that impact on platelets. Many of these drugs do lower platelets on their own, and here with the navitoclax, they dropped, but then did have some recovery. Adverse events, again, a recurring theme. It seemed that almost everything we do that has activity against myelofibrosis does tend to lower the platelet count, and here, no exception with this in terms of monitoring the disease. Here, finally, some of that data on luspatercept, showing that benefit both in patients not receiving ruxolitinib, improvements in both transfusion-dependent anemia, as well as people with Rux, no transfusions or off transfusions. So in this four-arm study, this suggests this has the greatest activity, non-transfusion dependent receiving ruxolitinib. I think premature to know which of these arms is best, but clearly active in all of these arms. Finally, the LSD1 inhibitor from Imago Pharmaceuticals. I have this as a trial as we speak at my institution, putting patients on this study. Again, the concept being that the inhibition of LSD1 helps to decrease inflammatory cytokines and other pathologic growth factors, leading to improvement in the myeloid clone as well as secondary manifestations. And in these early studies, they are seeing beneficial activity in terms of spleen, symptoms, and these features of the disease. So I've shown you many different therapies. How might they impact our management of the disease? Well, these are the current US NCCN guidelines for intermediate and higher risk myelofibrosis. So in individuals with a platelet count greater than 50,000, they have ruxolitinib as the main recommended therapy. They list, because of its approval, with a lower category 2B of evidence, fedratinib. I will share fedratinib, again, primarily is being used in this bucket here in terms of patients who've previously been treated with ruxolitinib who do not go onto a clinical trial. Individuals that are being monitored, etc., and if they are failing, that's where many of these other combinations are likely to factor in. The BET inhibitor, an alternative JAK inhibitor, a ruxolitinib combo, what have you. Perhaps, if approved, luspatercept or momelotinib might have an impact over here in terms of individuals with disease-associated anemia, pacritinib may again play a role here in these individuals with marked thrombocytopenia. If the BET inhibitor does show a benefit to individuals as upfront therapy, it would fall into this category here. I suspect that likely would be for a subset of individuals. Perhaps we will find a molecular marker or some other feature to really say which group is the most benefited here. And then finally, there's this group here, of which will be the focus of the case that you'll be hearing about, that are really still a big area of unmet need. What do we do with individuals that now have accelerated or blast phase myelofibrosis? And with that, I'll hand it back. Clearly, I've shown you a lot of work that is very team-based with collaborators from around the world. And our symptom data, I would call out our MPN Quality of Life Study Group for multiple institutions, and of course, the partnership of patients in developing these data. Thank you.
Thank you so much, sir. That was fantastic. Enjoyed listening to you. It was a lot of material, a lot of data, a lot of new things. Thank you, sir. And before we take the questions, I request now my colleague, Dr. Uday, from RNR Hospital, Delhi, to present a case to you, sir. Uday, over.
Yes, sir. So good evening to all. Firstly, I would like to thank Dr. M B Agarwal sir for giving this opportunity to present this case. And after listening extensively about MPNs, both polycythemia vera and myelofibrosis from Dr. Ruben, we will be just going through a very atypical case and not a very garden variety case. And we'd like to discuss few of the important burning issues with Dr. Ruben. So we have a 35-year-old male who presented to us with complaints of polyarthralgia of around a year duration with bony pains and easy fatigability of 1 month duration. The polyarthralgia primarily involved various large and small joints. It was progressive in nature and additive, in the form that it initially started as a monoarticular thing and gradually it became polyarticular, and it was also increasing in severity, so it was progressive in nature. It was not associated with any rash, sore throat, or any renal dysfunction. There was no history of any preceding viral fevers, particularly in India, the chikungunya or any of the viral arthralgic syndromes. The patient consulted an internist and he was prescribed colchicine and NSAIDs, but he had no relief with either of them. The pains had increased to a level that the patient had difficulty in performing activities of day-to-day living. The polyarthralgia worsened gradually to involve the intervening bones between the joints. Both long as well as flat bones were equally involved. The pain was excruciating to an extent that he was more or less bedbound. Consultation, who prescribed him opioids and patient-controlled analgesia with fentanyl. This worsening bone pains was also simultaneously associated with easy fatigability of around a month duration, which was insidious in onset, gradually worsening. And despite of increasing bedbound status, patient could categorically tell that he has worsening in fatigability even while walking up to the restroom. He used to get easily tired even in brushing teeth or in performing his activities of day-to-day living. And this feeling was very different from the bone pains or the joint pains that he had in the beginning. There was no associated history of any melena or bleeding from any sites of the body. This history was particularly taken because of a prolonged use of NSAIDs. So considering any occult GI bleed secondary to NS history was taken and it was negative. There was no history of any pica. This fatigability was associated with regular intermittent palpitations with gradual onset and offset and aggravated by exertion and relieved by rest. Most probably thought to be secondary to anemia per se. There was no associated chest pain. There was no history of any petechiae, ecchymosis, mucocutaneous bleeds or any decrease in vision to suggest any decrease in platelets during this fall in hemoglobin or anemia which was suspected from the history. There was no history of any other cardiovascular symptoms in the form of chest pain, orthopnea, paroxysmal nocturnal dyspnea, or syncope. There was no history of any hematemesis, chronic diarrhea, or any clay-colored stool. There was no history of any cough or hemoptysis. There was no history of any fever, weight loss, loss of appetite, night sweats, dragging pain or abdomen, or rheumatic complaints associated with this particular symptoms. There was no rheumatological complaints in the form of rash, oral ulcer, or alopecia, and no history of any swelling of feet, face, abdomen, or reduced urine output. No history of any polyuria, polydipsia, or polyphagia. The patient was married for 11 years and had one child. The spouse and children were healthy. He was vegan, no addictions in the form of any history of smoking, consumption of alcohol, and he denied any other form of drug addictions. Now, with a prolonged history of joint pains and bone pains, like in Indian scenarios, a very important history is of any history of any complementary medications, Ayurvedic drugs, heavy metal usages, or any homeopathic uses. There was no history of any such complementary medication use during this 1 year duration. In the past history, patient had any chronic illnesses in the form of tuberculosis, hypertension, diabetes, or any other disorders. He had one episode of jaundice in 2011, which was associated with prodromal symptoms. So most probably this was a viral jaundice, not associated with any fever, no history of any cholestasis, though the viral markers were negative at that particular point of time, and it subsided automatically with a conservative management with a 2 months duration. So it is of any doubtful relevance as far as the current episode of the symptoms are concerned. To summarize the history, we had a middle-aged man who presented with the history of polyarthralgia, bone pains, easy fatigability, which was insidious and onset and gradually progressive over the last 1 year, and with one anecdotal episode of jaundice in 2011, that is almost around 10 years back, with no other positive history. And with these complaints, he was referred to our center for a multidisciplinary care. The patient was examined at our center when he was found to be conscious, alert, and his performance status by ECOG was found to be 3. He had a low BMI of 19.41 kgs per meter square, but for otherwise well-to-do from family, having this BMI with some weight loss, though there was no overt history of weight loss, was considered to be slightly on the lower side. Temperature, patient had fever at presentation to our center with Tmax of around 101.6 degrees Fahrenheit with mild tachycardia. The other vitals, that is respiratory rate, SpO2, and BP, were well maintained. Patient had some pallor. There was no JVP rise, no clubbing of Polnakia, no other significant findings on the general examination, except for bony tenderness, which could be felt on palpation of various bones, both flat bones as well as the long bones. On systemic examination, patient had bilateral normal vesicular breath sounds. There was a flow murmur which was present. And on per abdomen examination, the spleen was palpable for 5 centimeters below the left costal margin in the long axis. And the liver was palpable for 2 centimeters below the right costal margin with a span of around 14 centimeters. The margins were rounded and there was no tenderness or any tenderness on percussion in the right hypochondriac area. On initial evaluation, he had anemia with an MCV of 95.4 femtoliters and a HB of 7.6 gram per deciliter. On peripheral blood examination, there were 35% blasts. The platelets were low, 58,000 was the platelet count. Otherwise, the KFT and the LFT, the liver functions and the renal functions, were within normal limits. The vitamin B12 was more than 200 picograms. This was basically done because initially he presented to us with anemia. So, and with a high MCV, so it was tried to rule out that particular part of it. Ultrasound abdomen showed spleen of 16.3 centimeters and a bone marrow aspirate was a dry tap. It was hemodiluted sample and showing only approximately 8% of the blasts. The imprint smears were taken, which showed around 16% of the blasts. The bone marrow biopsy was reported as acute panmyelosis with myelofibrosis with myelodyspoisis. Now, you could see these are the where you could see it's a hemodiluted sample and there are a few myeloid blasts which could be seen. Now, the bone marrow biopsy could classically reveal bone marrow fibrosis, extensive fibrosis. And on reticulin staining, it will be clearly seen that this is around grade 3 to grade 4 fibrosis by unit scoring. The flow cytometry, which was though done from a hemodiluted sample, showed around blast of 16.1% with these markers positive. The cytogenetic and the mutational panel revealed that the patient had FLT3 positivity. The BCR-ABL was negative, PML-RARA, AML-ETO was negative, JAK2 exon 12 and JAK2 V617F were negative. The CMPL and the CALR were negative. Now this JAK2, CMPL and CALR were done primarily keeping in view the myelofibrosis that was detected in the bone marrow fibrosis. The viral serology was negative. The tumor markers and the PET scan were done to rule out secondary myelofibrosis, and it did not add anything much to the evaluation because both of these reports were negative. The infection panel or the screen, which was done primarily because the patient was running high-grade fever, was found to have nodular opacities on the CT chest with some ground glassing present bilaterally with homogeneous, non-homogeneous opacities in the right lower lobe. The serum galactomannan was elevated, it was 1.2, and even the galactomannan from the bronchoalveolar lavage was also elevated, which was 1.42. The blood and the urine cultures were sterile. The serum procalcitonin was within normal limits. Now with this, the first question which I would like to ask the visiting professor today would be, how would we label this patient at this point of time?
Well, let me first ask the question. So obviously a very severe presentation. Kind of over what time frame did these polyarthralgias really arise? Was all of this just over a few weeks or a couple months, or had the patient been having symptoms for a longer period of time?
So as initially discussed, it was the polyarthralgia was present over a period of 1 year, which was gradually increasing in severity, whereas the bone pains and the easy fatigability, they were of 1 month duration.
I see. And there was really no prior history of any sort of clues of an MPN in terms of cytopenias, history of splenomegaly before. It sounds like it all really just evolved over this shorter time frame.
Yeah, probably because the patient was under direct evaluation by the internist as well as by the rheumatologist for almost around 10 to 11 months duration. But in the last 2 months, just before the presenting to our hospital, the patient was bedbound or was not able to go to the hospital. So leaving about the last 1 to 2 months, the peripheral blood smear previously had not shown any blast or any cytopenias, and there was mild there around 6 months before presentation, which was interpreted by the referring internist as secondary to NSAID use.
I would say, based on his age, the presentation, and the studies that you've done, really behaving like an AML at M7. It's always difficult to know with the acute megakaryocytic leukemias, are they the unevolved myelofibrosis, or are they really more of a de novo, but still very high risk type acute leukemia? I would tend to favor that it is, more of a shorter time frame AML de novo, although clearly megakaryocytic, on the basis of his age, the lack of an MPN driver mutation, and the lack of any sort of kind of prior history to really suggest a longer course of disease. Most of our true blast phase myelofibrosis will likely have had a much longer disease course, likely are clearly older than this, and had a period where we recognized splenomegaly, cytopenias, symptoms, and evolved. So still a high risk no matter how one considers it. With the current WHO criteria, again, it's got the FLT3 mutation that one can anchor off of, but clearly a megakaryocytic in biology.
So for the I would appreciate that this could be megakaryocytic, but there were two particular quite. There was no blibbing of the blast or the budding that we generally see in megakaryocytic AMLs. That's number one. And second, such an extensive fibrosis which was seen in this particular patient, and splenomegaly which was noticed, the hepatosplenomegaly.
Again, without these individuals, we never really have the run up beforehand in terms of data, labs, or other things. It certainly can be MPN blast phase. It's just tough to know. But again, I would say at a minimum, very atypical. We clearly can see fibrosis in the M7s as well as again, splenomegaly. These are a very uncommon type of acute leukemia, kind of regardless. I think management-wise, it probably doesn't make a big difference, as you get around to the management piece. But the age really is quite an outlier.
All right. So I'll like to go further with the case then.
Of course.
So how would you manage this patient at this point of time, given the case history and the presentation and the bone marrow findings? What would be your take as far as managing this patient would be concerned?
Well, fundamentally, these situations are always very high risk. And clearly you're trying to get the patient stabilized from the infectious standpoint, as clearly, one key piece. But I fundamentally put these patients really into two categories. Is this an individual that we are likely going to be able to move toward a curative path with a stem cell transplant, or is this an individual that we're going to be trying to improve quality of life and extend life? Clearly, given the age of the individual, we highly desire to try to get them onto a curative path. So trying to achieve the best cytoreduction and remission that one can is really the key. There clearly are multiple approaches. I do think an individual like this, again, it's reasonable to begin them with a ruxolitinib-based accelerated or blast phase type regimen. According to our NCCN guidelines, one clearly could start with Rux plus a hypomethylating agent, perhaps consideration of something active against FLT3 given the FLT3 mutation that the patient has, but clearly with other more aggressive, less targeted chemotherapy as a backup if a good response is not achieved. Including all with the goal of getting them to a transplant.
Okay, so we more or less did the same thing as was advised or as was explained by Dr. Ruben. So we gave this patient a hypomethylating agent, considering his infections and the CT chest showing nodular opacities and ground glassing and his raised galactomannan with some background possibility of having some fungal infection. So considering that, we gave him antibiotics, antifungals, and viral prophylaxis. Along with hypomethylating agent, we started him on decitabine with ruxolitinib and sorafenib. Ruxolitinib, we started at 5 milligram BD, considering his low platelet counts of around 58,000 was his platelet counts at presentation. So we gave low dose ruxolitinib to begin with. And for the FLT3, we have started sorafenib at that particular point of time because the other drug was not yet available that around a year back when this patient had presented to us in our setup. So considering that this was started and a repeat bone marrow was done at the end of 2 cycles, the aspirate was again a dried up. The imprints had shown around 20% blast now, and the biopsy was suggestive of fibrosis with 32% blast with grade 3 fibrosis. This marrow at this point of time was done just to be sure that we are on the right track. Do we need to upscale the therapy or anything further to be done? But to our surprise, definitely the blast, when we compared both the morphology of the initial slides and the slides after 2 months, we realized that the blast percentage had increased in number when compared to the beginning. So we were really puzzled. What was the cause of rise in the blast? Okay, we understand that the hypomethylating agents do take some time around 4 to 6 months for them to start acting. But a rise in blast was something which we were not able to explain. So could you give some explanation for this?
It's difficult to know. I think that there can be a couple factors. Of course, you're improving the curve of the disease change, hopefully from what it would have been doing without therapy. So although it increased, it's difficult to know without therapy, what would that number have been. The second part is, in the setting of that extensive fibrosis, the exact blast percentage is more challenging sometimes to really wrap your head around. Both the blasts that are arising from sometimes from the spleen, as well as trying to get accurate counts given all the fibrosis and less cellular areas from the marrow. So I can't say that this is a kind of a reproducible thing we see with treating these folks, but it is challenging. And again, in the setting of kind of a non, strongly myeloablative regimen, it is a very slower dynamic. I do think you chose wisely. Again, giving someone like this traditional 7-3 chemotherapy would have been difficult given the infections and the potential of really having, a fungal infection become more advanced or have a life-threatening infection. So I would certainly, keep on the path that you're going and not be overly discouraged just because the blast percentage hasn't done exactly what you wanted.
Professor M B Agarwal, sir, any comments at this point of time? Would you like to change the therapy at that point, or would you like to continue with the same therapy with your experience in Indian scenario in such a patient?
No, I think
I might try. If the patient's doing better, I might try to go a little further on this line.
Yeah, go ahead, Uday.
So in the meantime, we actually got our HLA matching for the patient, and to our luck, we had a complete match with the sibling. So the patients had repeated episodes of febrile neutropenia even with this form of therapy. His febrile neutropenias used to respond to the empirical antibiotics and culture-driven antibiotic therapy. The patients were continued with hypomethylating agents. We gave 4 more cycles of HMAs, hypomethylating agent destabine, and ruxolitinib. We had to stop sorafenib owing to the intolerable itchy rash over the limbs and various other skin-related side effects of sorafenib. The polyarthralgia and the bone pain had subsided by 4 cycles or 4 months of therapy. The spleen side had decreased by around 4 months. So initially it was 5 centimeters below the left costal margin and 16.5 centimeters on ultrasound, which had come down to 1 centimeter below the left costal margin, and the ultrasound size has shrunken by around 3 to 4 centimeters. We did a repeat bone marrow evaluation at the end of 6 cycles, which showed a slight decrease in the grade of myelofibrosis, though we took it with a pinch of salt, maybe not the representative ratio or whatever it is, because we were not expecting too much of a change as far as the myelofibrosis is concerned within 6 months of therapy. So at this point of time, this was a type of rash that the patient had, as you could see on the chest, on the limbs, on the peripheries, so which was very classical of sorafenib-induced rash. And this was intolerable. Whenever we used to reintroduce, the patient used to have a repeat rash, so we had to stop sorafenib in between. So now coming to the question, because now this patient had a fully matched sibling donor, and we have given almost 6 months of ruxolitinib therapy with some decrease in size of spleen and some decrease in the fibrosis, bone marrow fibrosis. So what would be the role of ruxolitinib in pre and post-transplant scenarios in such cases where we are not thinking of a primary myelofibrosis, but probably thinking of AML with myelofibrosis?
Well, I think the patient has clearly benefited, and I would certainly leave it on as a therapy. In your standard myelofibrosis-related transplant, I do think that patients benefit from being on ruxolitinib pre-transplant, both in terms of improved performance status, improvement in the size of the spleen, in terms of decreasing cellular sequestration with the transplant. And as a separate item, does it have a benefit in terms of decreasing graft versus host disease afterwards? There are a variety of approaches that clearly are being investigated at the current time, whether it is wise to keep it going during the transplant as some sort of maintenance or as a post-transplant setting. And I think that is certainly not unreasonable in that, this individual, even with a successful transplant, certainly has to be viewed as being a high-risk individual. So I do think it's very reasonable to keep it going. In a case where the time course is shorter, still would probably consider trying to weave it in as best able and tolerated, particularly in situations like this.
Now, if this patient had to be taken up for transplant, as is planned in this particular case, would you be continuing it during the conditioning regimen and the immediate post-transplant period, or would you be stopping it at certain stage before the transplant and start it after engraftment post-transplant? So how would be the ruxolitinib in a practical bedside case scenario for the students and for various practicing physicians? How to go about using ruxolitinib in peri-transplant period?
I can't say that there's an international consensus with this. There certainly are trials and experience of people keeping it going during conditioning and into transplant at a lower dose, given the thrombocytopenia and other things. In a case like this, given their youth, given the features of the disease, given the high-risk nature of the disease, I might consider keeping it going at a low dose during the course of the transplant itself.
Now, considerations for a role of sorafenib pre and post-transplant in such patients who also have a FLT3 positivity. Though I understand this is slightly tangential, but
I'd say that I probably have more direct experience with. In the U.S., we probably have used midostaurin or others as our FLT3 inhibitor. But I think given the FLT3 mutation and using it really in the setting of trying to inhibit FLT3, I think how you try to use it is very reasonable. Clearly in this individual, the allergic rash is and the sorafenib rash really make it not feasible for him. But if it had been well tolerated, I do think it's very reasonable how you have done it.
Now, combination of sorafenib plus ruxolitinib, because in India, midostaurin is extremely costly and not many patients can actually afford midostaurin. So a combination of sorafenib and ruxolitinib, because there is the issue of cytopenias when we give both the nibs together.
It's a good question. The number of individuals that have both a MF blast phase and FLT3 still has been fairly limited. So there's still fairly limited data in terms of combining both. Again, I do think they each bring, at a minimum, an additive benefit to the combination. So I think trying to use them together, has been very reasonable as you've shown. But obviously, the number of individuals that have received this that have been reported is still fairly modest. So how best to manage the cytopenias, it's to know. But given that the short-term goal is in particular regarding disease control, I think trying to use both at an efficacious dose with transfusion support is reasonable.
So this particular given patient, so we took the patient for an allogenic transplant with a HLA matched sibling donor who was a younger brother, and with a transplant with fludarabine and melphalan conditioning with adequate CD34 dose. The patient engrafted 17. The post-transpose has been fairly smooth with not too many complications except a grade 2 mucositis, which could be managed with conservative therapy. And by day 30, post-transplant, the patient had a hemoglobin of 9.5 with a TLC of 3,700 and a platelet of 9,000, with LFTs and KFTs being normal, chimerism being 100% donor chimerism by day 30 post-transplant. The FLT3 was negative. The bone marrow which was done was a hypoplastic marrow with no atypical or immature cells, but persisting fibrosis, and the ultrasound abdomen had been reported to be normal post-transplant at this point of time, which is almost around 8 months to 9 months post the initial diagnosis. The current status, the patient is D plus 286 now, as of now. He's off all the immunosuppression. There was no evidence of GVHD. There are no active issues. He received sorafenib for 3 months post-transplant. His ruxolitinib is continuing as of now. We are giving it for both the purposes, one for the myelofibrosis and second for prevention of the graft versus host disease, because in our scenario, we really had a very good experience of using ruxolitinib for both acute as well as chronic GVHDs, though the data for acute is not fairly good as far as the literature is, but we have used it for both the scenarios. So we are continuing on ruxolitinib as of now. So his current counts, the HB, TLC as well as platelets are very good. In fact, they have come to a near normal range. The KFTs and LFTs are normal, and the patient is doing quite well with an ECOG of 1. So the patient is really doing very well as of now. So last 2 or 3 questions would be, how long after transplant does the fibrosis reverse? If we keep giving these patients of myelofibrosis post-transplant, so when can we expect the fibrosis to reverse?
It really is a surprisingly slow process where we really see that from 6 to 18 months of the fibrosis improving and the splenomegaly kind of completely resolving in individuals with a larger spleen. So it's really quite a slow process. The question of what is relapse and what does response in myelofibrosis transplant look like is difficult to judge in the short term. In situations where we have the presence of the JAK2 mutation, we do know that resolution of that mutation in the first 6 months is certainly a very favorable outcome to see, but the fibrosis can really be quite slow in resolving.
The duration of JAK2 inhibitors in such patients post-transplant, how long should we give? Now this patient is almost around months post-transplant, and he has received for 6 to 7 months pre-transplant, so 17 months of ruxolitinib he has already received. And that too, this patient is a JAK2 negative patient to start with.
It is difficult to know in that there really have not been any comparisons of the post-transplant strategy to see which is truly best. There's multiple reasons to think that there may be benefit in terms of decreasing the risk of GVH, in terms of possibly having some benefit against the abnormal clone, allowing the graft versus leukemia effect to further be beneficial. I think trying to keep it going, clearly the risk of relapse is the greatest in that first year, 18-month type time frame. I think continuing going for a year to 2, if it's well tolerated, is reasonable. But truly there is no great data yet to guide the duration. But if they're tolerating it, we know that relapse is catastrophic in such a young patient with a difficult disease. So I think, as you've done, I think trying to be conservative and give, the most therapy to try to control the disease is reasonable.
He suggested modifications in the isn't very huge as far as we young physicians are concerned. So any particular care that we should take in such myelofibrosis transplants?
Well, I think you've taken excellent care of this patient, and clearly the additional complication of them really presenting with the potentially severe infections. I'd say as a general comment that, the experience has been that early transplant, the earlier one is able to do the transplant in the cytoreduced patient, overall, likely the better the outcomes, still realizing it's a very high risk situation regardless. So if the patient had not had infections or things of that nature, might consider a bit more aggressive approach particularly earlier on in the course, followed by transplant. That'd be the only kind of perhaps slight modification, but in the in the non-infected patient, if you weren't happy with that hypomethylating type approach, again, might go for a more traditional cytarabine, anthracycline, plus FLT3 inhibitor plus Rux, type approach.
Last question, any newer modalities, because you have really presented so many newer drugs as far as the therapeutic armamentarium is concerned in your talk. So in such a case, any other drug which you would have given to this individual if you would have been directly under your care?
I wouldn't say necessarily, but other things that might be in the mix. If we had seen an IDH1 or IDH2 mutation, those therapies clearly might have benefit to be included in the mix. There's a lot of discussion whether there's any benefit from the addition of venetoclax in the mix for these individuals, along with the hypomethylating agent. And there's some data that are evolving, so that's a maybe. In the States, we might, of course, have used midostaurin, but that might just really be an access issue as well. All those drugs I showed you in terms of being developed, they're really being developed in the myelofibrosis type setting, and probably less relevant for this grouping. There are new AML type therapies that are evolving. So the other thing in the mix, it was just approved in the US this week. Is there a benefit? Tough to know, but there is an oral azacitidine tablet that has been developed. And is there any benefit to a maintenance oral azacitidine in the post-transplant setting in someone like this that's had a response? Again, yet to be proven, but it is at least possible that the new oral azacitidine might play a role as well. But I think probably most relevant is I would have looked, again, probably unlikely to be present given his age, but an IDH mutation, whether that would be, if that was present.
Thank you, sir. Thank you for answering all the questions and clarifying and enlightening us with how to manage in an ideal case scenario. My last question to Professor M B Agarwal, sir. Sir, any other additions in pre-transplant, transplant, or post-transplant care for this particular case, as per with your experience?
Thank you, Uday. I have nothing to add. Thank you very much. This was a wonderful case, and both of you discussed it extremely well. Professor Ruben will take a little break now, and we will have a few questions to be discussed between Uday and myself. So, Professor Ruben, you can join us back after a while. For the moment, we have some questions. Dr. Uday, would you like to answer this question? Can people with hemochromatosis donate blood?
Definitely not, because now with the growing evidence that hemochromatosis patients do have multiple mutations to come up along with, so such patients are not advised. The same also applies to polycythemia, that polycythemia patients, because of a rarer risk of transferring the mutation to a healthy individual. So the current ABB guidelines do not allow transfusion from either of the cases. But anything new or anything specific with which Agarwal sir wants to add onto this particular question?
I think that's absolutely fine. This becomes a drop in the ocean really with compared to the transfusions you give. And the AABB regulations do not permit you to take blood from a diseased person because of various risks which Uday just discussed. Another question, Uday, for you is, can you really use the blast percentage from a diluted marrow as a criteria to diagnose AML?
Not exactly. We understand this is a particular problem with patients who have got a dry tap, or those patients who get a hemodiluted taps and myelofibrosis. Neither the flow cytometry percentage nor the hemodiluted marrows can be used as a criteria for diagnosis. But maybe imprint smear can act as a close surrogate for getting onto the blast percentage for such patients.
Thank you. Another question for you is, which are the JAK inhibitors available in India?
So as of now, we only have ruxolitinib. No other JAK2 inhibitors are currently legalized as far as the Indian case scenario is concerned.
Okay. Now you are from Army set, so this is a question relevant to you. No, I think we'll skip this for Professor. One simple question is, can you diagnose primary polycythemia vera without JAK2 mutation being positive?
Yeah, we can. As far as the WHO classification is concerned, we can use the older techniques, the older classification criteria by the HB level and by the presence of EPO, the EPO maturation, the growth cultures using erythropoietin can be used for diagnosing the polycythemia vera. But with the JAK2 coming in, it has made the life very easy for diagnosing the polycythemia vera with more accurate and appropriateness.
And about 4-5% of patients can be exon 12 mutation.
True.
Yeah. Is there any place for allopurinol in management of myeloproliferative neoplasms? Can there be a tumor lysis if the count is very high?
Not generally, because most of these cells are mature cells, so their chances of leading to a spontaneous tumor lysis is extremely low. But a therapeutic possibility is there, particularly in blast phase of myelofibrosis, where the patients might need a uric acid lowering drugs. But otherwise, generally in patients with PV, ET and cellular phase of myelofibrosis, considering the mature cells, so a tumor lysis might not be, a spontaneous tumor lysis might not be a possibility.
Another question is, what is the definition of neutropenia?
This can be very variable. It's a very good question, and whoever asked this question, I totally appreciate that, because sometimes the people label it as less than 1,500. You go as per MACC guidelines, they have a different classification. The European guidelines are different. So 1,500, 1,000 and 500 all have been labeled, but it all depends upon in which case scenario are we looking at. If it is for defining febrile neutropenia, the numbers are different. If we are looking at for neutrophil engraftment, then the numbers are different. So the comfortable figure is less than 1,000, which can be taken. But in fact, there is another, other than the 1,500 and 500, the person who has asked, even 750, there are guidance for 750 also.
Have you ever switched a patient from ruxolitinib back to hydroxyurea?
Multiple number of times, because of 2 or 3 reasons. One, somehow, I don't know whether it's a problem in our setup or generally across the country, we have seen quite a number of patients having tuberculosis secondary to ruxolitinib. The patients who are doing very well on ruxolitinib, after 3 months, 4 months, landing up with tuberculosis, number one. Number two, ruxolitinib leading to thrombocytopenia and the platelet counts not rising despite of whatever we are doing is another case scenario where we are. And third, sometimes a rise in the LFTs, particularly seen with ruxolitinib. All these 3 case scenarios we have seen wherein we had switched them back to hydroxyurea as the best available therapy.
Okay, in a case of polycythemia vera, is there a particular WBC count on which you will start cytoreductive therapy?
Yes, because there are guidelines, and in fact, if we look at the incidence of thrombosis, so one of the major criteria for thrombosis and in fact the scoring for high-risk polycythemia vera, the TLC count is considered as a cutoff for that. So people vary from 10,000 to 13,000 to 18,000 and 20,000 as cutoffs. Different cutoffs and different studies have used for increased incidence of thrombosis. So we can consider an increased TLC as a criteria for starting cytoreductive therapy in such patients.
Is there any level of ferritin at which you will start iron therapy in a case of polycythemia?
Ferritin less than normal levels. So other than that, sir, this you might answer better. You are the Iron Man of the country.
Thank you. Will you like to answer this? Your experience in managing Jewish polycythemia patients, any role of cytoreductive agents in patients whose symptom burden is not controlled with phlebotomy plus aspirin?
This must be definitely from some army personnel, because we do quite a lot evaluation for evaluating the type of polycythemias. Yes, we have had around 7 patients of Jewish polycythemia in our series of 283 patients, which we have recently sent for publication. So the role of cytoreductive therapy in such patients is really questionable because it's mutation-driven polycythemia in such patients. But yes, we do going for phlebotomy plus ecosprin in such patients, ecosprin lifelong and phlebotomy any hemoglobin more than 17.5 or with vasomotor symptoms, we subject them to phlebotomies.
What is the duration of anticoagulation in a patient of polycythemia vera who has developed portal vein thrombosis?
This is again a very good question, and I would say it would be a lifelong anticoagulation therapy. But after 6 months to 1 year, depending upon if the D-dimers have normalized and if the patient is persistent of normal D-dimer levels, after 6 months with recanalization of the portal vein, shifting from oral anticoagulant to ecosprin is a decent option. Again, we have an experience of this of around 100 patients of the portal thrombosis from various army institutes, and we have seen that ecosprin does quite good in preventing any recurrences.
If a polycythemia vera patient is iron deficient, will you treat it?
Yes, we would, because it's like these are two different angles altogether. Though it is understandable that trying to keep these patients iron deficient might help in preventing the HB from rising, but at the same time, iron has many other roles in the body to play other than just rising the hemoglobin.
Thank you. There is a patient of polycythemia vera since 1 year. He is diabetic. He has no other high-risk feature. He is 37 years old. There is no enlargement of spleen. He receives. He is on phlebotomy every 4 months, and he is on low-dose aspirin. His hematocrit still remains 53 to 55. Should it be brought down to 45?
No, if no vasomotor symptoms, then we don't follow that. Considering the Indian case scenarios, but I'm not sure about the absolute NCCN guidelines for the same.
I would say that, in the ideal world, based on the cyto-PV data, to really try to keep that hematocrit, under 45%. So if the hematocrit is, running 53 to 55, that does leave the individual with a higher risk of vascular events. Now, obviously, that's always balanced against the way that the patient is tolerating phlebotomy, but I do really try to keep the hematocrit under 45%, especially with the diabetes clearly does increase the risk of vascular events, earlier on in the course of someone's life.
So in a female patient also, we'll keep it 45 or make it 42?
I would say less than 45. It might be less than 42. The cyto-PV study did not really have kind of a sub cutoff. There's really not been an independent trial that's really looked at 42 versus 45. I do find many women clearly have better improvement in their symptoms being under 42. So it's at least under 45, but potentially under 42, and I will use how they are responding in terms of symptoms to help clarify that. The initial recommendations of 42 for women was based off of a mathematical calculation, but was really never vetted in a trial setting to be necessary that it be a lower threshold for women.
If there is a patient of polycythemia vera who has iron deficiency, will you correct it?
It depends if they are on cytoreductive therapy that will otherwise control the counts, then potentially yes. So that's a situation where again they would need to almost certainly be on hydroxyurea, ruxolitinib, etc. Because if they're solely on phlebotomy, if we give them iron, it will just lead to the need for additional phlebotomies.
Sure. There may be some questions that you have already covered in your lecture, but at the cost of repeat, I will still ask them. You may or may not answer them. The question over here is, how do you treat a case of myelofibrosis having constitutional symptoms or large symptomatic splenomegaly but at the same time, severe anemia with hemoglobin of 7.1.
So the first key is that this is a patient who will benefit from being on ruxolitinib. And we have looked at this, even in the setting of anemia, they still benefit from being on ruxolitinib, even if they have anemia or transfusion dependence. It probably still helps to improve survival, it helps to improve quality of life, it helps to improve the spleen and the symptoms. Now, to also try to improve the anemia, we may, I would start them on ruxolitinib first, see how they're doing, etc. And work to still get them to full dose. We may consider over time if there's not improvement in anemia, or sometimes there can be, not initially, but over time because of improvement in splenomegaly, decreased splenic sequestration, decreased inflammation. We may consider in this group, again, over time, the addition of danazol. We have had trials where we added danazol to ruxolitinib with benefit at 600 milligrams a day. There have been trials of the addition of thalidomide and prednisone to ruxolitinib, an ESA such as erythropoietin if the ESA is level less than 500 in the blood. But I would not let anemia stop starting ruxolitinib for the symptomatic patient with splenomegaly and symptoms.
Will you start with low dose ruxolitinib or the standard dose?
I would probably start with low dose, but with the important need for increasing the dose. Patients benefit the most by being on at least 10 twice a day, if not 15 milligrams twice a day of ruxolitinib. Having had many patients of a full spectrum, the anemic patient is going to be anemic kind of regardless. So they're better off being anemic with ruxolitinib than being anemic kind of without ruxolitinib. The transfusion-dependent patient still benefits from being on ruxolitinib. If we can improve the anemia, great, but even if we cannot, they're still better off being on the ruxolitinib.
Thank you. Your answer is going to be a practice-changing answer. A lot of people in India hesitate when they have anemia and transfusions going on in using ruxolitinib. So thank you very much for clarifying this.
Yeah, it's a very important point in that in terms of survival and the longer-term course of the disease, the patients really are better off being on ruxolitinib, even if they need transfusions.
Great. You touched upon this role of luspatercept in treatment of myelofibrosis-associated anemia. How effective is it?
It clearly is helpful. The response rates from our other study suggest improvements in at least half of the patients or more. I think it's still not kind of approved in that setting, but I anticipate that approval likely will come. And that it will be probably an important addition to our armamentarium to add to patients, just like the question you just asked.
Thank you. Moving from anemia to thrombocytopenia. So you have a similar situation, myelofibrosis, constitutional symptoms, a large spleen, but platelet count is 36,000. How do you handle?
Well, slightly different scenario than the anemia, but still relevant. So here, I do think that starting at low dose, particularly if you don't have access to the pacritinib trial, etc., is important, because the platelets can drop at first, but then do stabilize, and sometimes don't drop in patients who already have significant thrombocytopenia. They sometimes don't drop that much or don't drop at all. Because the balancing factor is that there's improvements in the size of the spleen, less splenic sequestration or destruction of platelets. So I might start someone like this on 5 milligrams twice a day of ruxolitinib, but, and this is the important part, continue to increase the dose based on their response. So there are individuals like this who are able to be treated on 15 milligrams twice a day of ruxolitinib, sometimes without the platelet count necessarily dropping any more than where it is. Sometimes over time it goes up. So I would probably start it lower and give it, 2 months or so, to have a chance to see how the platelets are going to behave, and then further increase the dose. So we do have individuals just like this who that are on full dose ruxolitinib. They do benefit. Their platelets are still low-ish, but they are better off. Additionally, we do not tend to see, significant hemorrhagic complications usually in this group. So the one thing we've not seen with all of these longer-term follow-up studies is really any signal of ruxolitinib-associated hemorrhage due to thrombocytopenia. So although it's a concern, fortunately, it has not translated into significant bleeding risk.
Thank you. That's another great answer, because this is another practice-changing answer. A lot of people fear bleeding and hesitate. So that's fantastic. Will you ever use thrombopoietin receptor analogs in this situation?
They have been tried. They've not been overly effective for this group. They do have the concern that they may increase fibrosis in the marrow. So I can't say that we've used them to a significant degree, but for the largest part, they have not been very effective.
Right. Tell us about ruxolitinib discontinuation syndrome.
So I think that there's kind of two aspects. One, when we stop ruxolitinib in a patient, typically there will be a period of time where the spleen regrows or their symptoms worsen. So weaning patients off of ruxolitinib is helpful rather than abrupt stopping it overall, because patients will not feel well if you stop it abruptly. That being said, there are, many global experiences, thousands of where patients stop ruxolitinib to go on to a clinical trial. They run out of the drug, they didn't have the refill, they went on a trip and they lost their bottle, whatever, that did perfectly fine. There is a very small minority that do seem to have a more significant response to stopping it abruptly, particularly if they were already ill. So for example, if somebody was septic and they stopped ruxolitinib, then they clearly did worse. So there have been, very low rate of, let's say, kind of a cytokine storm in the setting of stopping the drug, but usually in the setting of somebody that already has a physiologic stressor. So in parallel with this, what about COVID-19? So Dr. Tiziano Barbui shared with us last week at our Texas MPN workshop some of their evolving data from Bergamo. And Northern Italy had a very sharp spike of COVID-19 cases in the spring, as we all know. And they saw that individuals that were on ruxolitinib who stopped it after having developed COVID-19 and were hospitalized did dramatically worse than those individuals in which we kept the drug going. So one, ruxolitinib discontinuation syndrome, I think, is really a rare phenomenon, but it has happened usually in the setting of physiologic stress. But a key takeaway, if your patients develop COVID-19, do not abruptly stop ruxolitinib unless if there's really a clear reason to do so.
Thank you. How do you manage Rux therapy in a case of myelofibrosis who has developed pulmonary tuberculosis? Will you stop it?
Well, that is tricky, but again, these are one of the infections that we do have a concern regarding the safety and the immunocompromised state in the setting of TB. I think it would depend on the clinical situation in terms of how much they needed it, which TB therapy they were going to start on, etc. But this would be a consider weaning them off and getting the TB adequately treated before considering a resumption of the ruxolitinib.
Thank you. A similar situation, the patient develops herpes zoster.
In these situations, again, we will try to continue on the ruxolitinib, particularly if they are benefiting from it. I think the key is very early use of antiviral therapy for these individuals to diminish the post-zoster neuralgia and the duration of the herpes zoster infection. So I usually have patients kind of alerted to this possibility so that we start antiviral therapy early and that there's not a prolonged period of time before the diagnosis of zoster is made.
Thank you, sir. Your comments about RUX-based combination in treatment of myelofibrosis, you have mentioned about all this. Ruxolitinib with hydroxyurea, ruxolitinib with hypomethylating agents, and ruxolitinib with thalidomide prednisolone danazol.
So what I'll make the comment that for the most part, ruxolitinib has able to been safely combined with most things that people have tried. So there probably have been almost 50 different trials of ruxolitinib being used along with another drug. And so far, it's fairly safe to use with darn near about anything. But the situations clearly in terms of goal are different. So that with hydroxycarbamide, I'd say the goal of adding hydria would be in a very specific situation. So the rare individual that has massive leukocytosis, a white blood cell count of 100,000, has more accelerating disease where control of a very high count, or let's say the individual that has been splenectomized and has a massive thrombocytosis, that's where the addition of hydroxycarbamide can be helpful, controlling really a very high white count or a high platelet count. It's not very helpful for trying to further control splenomegaly, symptoms, disease progression, anemia, etc. Rux in a hypomethylating agent, very much like the case that we just saw Dr. Uday discuss in terms of accelerated or blast phase. And thalpred and danazol, again, I think they're really with individuals where we're really trying to improve cytopenias. So each really for different scenarios.
Thank you, sir. Your comments regarding non-pharmacologic management of splenomegaly, that is splenectomy, you talked about it, and splenic radiation.
So as it relates to non-pharmacologic therapy, I will add in the mix that patients clearly do benefit from structured exercise. It does help with the fatigue, as well as we have done randomized studies of course, the Indian practice that influences the rest of the world in yoga. So activity, yoga, meditation do help with the symptoms and the burden of the disease. So I keep all of those things in mind, and that India has long been a leader in some of these practices. Now, splenectomy, I think, as I had mentioned, again, I would really view in a very select group, individuals that I think have a very prolonged survival, but the spleen is really quite recalcitrant to medicines and has not responded. So we still do it, but at a much less degree. The important caveat we've learned as well, if you do splenectomize someone, is to be aggressive with controlling the platelet count and or the white count post-splenectomy to be sure that there's not a thrombotic event. Splenic radiation falls in a similar sort of category. Using it briefly, it can shrink the spleen, typically not for a long period of time. It probably is the most helpful in the more refractory splenomegaly that did not respond adequately to JAK inhibition pre-transplantation. So that's where I think I've seen it used most convincingly, because its benefit is short-lived. So I would clearly do it, 3 weeks before a transplant, etc., with a goal of trying to have less splenomegaly at transplant in the patient more refractory to JAK inhibition.
Thank you, sir. Your comments about prevalence, prevention, and management of pulmonary hypertension in myelofibrosis.
It's a very interesting question, and it is a challenging manifestation of the disease. And it's one that I think that we don't recognize enough in individuals with the disease. The prevalence is difficult to know, but I suspect it's probably, somewhere between, 5 to 10%, but probably, lower, 5 or a little lower if you consider in terms of severe pulmonary hypertension. I do suspect that earlier therapy, and I do suspect JAK inhibition probably does have a benefit in terms of preventing this from developing. We obviously don't have data to really prove that assertion, but at least mechanistically, I suspect that is likely the case. Now, if they have pulmonary hypertension, JAK inhibition may be beneficial. But we clearly do know that low-dose radiotherapy to the lungs can clearly be beneficial. And really quite low dose, 100 centigrade, things of that nature. But the most important part is to be aware of this potential complication and to really perform echocardiography, or if necessary, a right heart catheterization in the patient with unexplained dyspnea or cardiac symptoms with myelofibrosis.
Thank you, sir. Any comments about pediatric myelofibrosis?
So it's a good question. I work closely with my colleague, Dr. Nicole Cuisine, who is a pediatric MPN-focused individual at Memorial Sloan Kettering. They are few and far between in terms of individuals with this as a focus. Pediatric MF is really quite uncommon. It's probably much more likely to find under the age of 18 patients with ET or PVERA, and they clearly can have similarities to adult disease. How we treat them is more difficult to know, but we probably rely much more heavily on consideration of pegylated interferon in this group. If it's a truly very young patient with myelofibrosis, under the age of 10, I'd be highly suspicious of it being associated with a different hematologic syndrome associated with myelofibrosis. So do they have a variant of Downs or some other congenital abnormality that has led them to have cytopenias and MF, but not necessarily a classic JAK2, CALR, or MPL-driven myelofibrosis?
Thank you, sir. How important it is to separate out pre-fibrotic myelofibrosis from ET? How do you make a definitive diagnosis, and what is its impact on prognosis and treatment?
I think the main difference between these two entities is really longer-term prognosis. And it's not clear that it really makes a difference in terms of our therapy. It might make a difference really in terms of our surveillance of them in terms of the disease, but I still think we manage them according to what is in front of us. Their symptoms, splenomegaly, control of the counts. I do think that this is an entity where, again, I might be more inclined to consider therapies like pegylated interferon that might help to slow progression. Likewise, I might be more inclined to consider ruxolitinib in individuals as they're having symptoms, splenomegaly, or evidence of movement in that direction.
Thank you, sir. Your opinion regarding inflammation in the biology of myelofibrosis and other myeloproliferative neoplasms, and any comments about immunotherapy?
So there clearly is inflammation that occurs as a result of the clone, and is part of, I think, the vascular risk and part of the symptom burden without question. And that's, I think, one of the reasons why the JAK inhibitors have been, highly impactful. In terms of immunotherapy, I think that there is great promise, although I don't think that it is necessarily related to checkpoint inhibition. I think our immunotherapy still remains somewhat crude. So the trials looking at checkpoint inhibition alone or in combination with JAK inhibition don't really seem to have been particularly positive. Longer term, immune-based therapies against and antibody therapies against, let's say, calreticulin might hold great promise. If a calreticulin is on the cell surface and might be amenable to vaccine-based therapies or antibody-based therapies against the disease. So I'm sure immunotherapy will have an impact. It just isn't there yet. Likewise, CAR T type therapy clearly has great promise, but still is somewhat ablative. So what target and how to get CAR T therapy to work in these diseases is still tough to know. At the current time, probably only in concert with stem cell support.
Thank you so much. What is the impact of non-driver mutations in the treatment, including transplants, in MF and other MPNs? And should one routinely do NGS for non-driver mutations?
I think they are very important in terms of prognosis. And in the patient in which you're potentially considering transplant really can be very helpful. I'd say, it would be nice to know in everyone, what does it help in terms of management? I think is really around that issue of transplant. Likewise, it may influence therapy in people with more advanced disease. So as you mentioned, the IDH1 or IDH2 mutations might have had relevance in the case that was discussed in terms of options with MPN blast phase. But for your standard older non-transplant patient, they probably don't make a difference yet in terms of the decision of beginning ruxolitinib or the other therapies that we currently have available for standard myelofibrosis.
Can this be done from peripheral blood with equal success, or it has to be from bone marrow?
Overall, it can be done from peripheral blood, usually with equal success. And indeed, many of the time when we get marrow, so often it's really a dry tap anyway. And even if we get blood from a bone marrow aspirate, frequently it's probably peripheral blood anyway because of kind of what we're pulling off, with the fibrosis. So I do think peripheral blood is usually adequate for these folks.
Thank you. Can MPSS70 be used to assess the prognosis at any time during MF, or it is best used at the time of diagnosis?
Yes, no, it can be used dynamically, which makes it much more helpful. So yes, like the DIPSS, it can be used throughout the course of the disease.
Right, sir. How do you diagnose masked polycythemia vera? Does the prognosis and treatment differ?
I don't really think that it does. I think masked polycythemia vera is still polycythemia vera. The numeric cutoffs that we developed, as a field are somewhat arbitrary, and just because someone does not rise to that specific level of hemoglobin, that of course might be a reflection of the individual being iron deficient. So I see in particular women of the age where they're still having menstrual periods. They clearly have polycythemia vera, but many of them will not have a hemoglobin that rises to that arbitrary number because of iron deficiency. So I do think largely the prognosis and treatment are really quite similar, particularly in the setting of the defining JAK2 mutation and disease manifestations.
Right, sir. In the era of molecular testing, what is the significance of low erythropoietin level to diagnose polycythemia vera?
Helpful in the JAK2 negative P vera patients. There are still some patients that do not have either the classic JAK2 V617F or exon 12 mutation that have PV. And it is there really where the EPO level and the bone marrow histology are really helpful in trying to make that diagnosis. So it's not common, but it's not, but it is a real entity.
What is the implication of persistent high leukocytosis in patients of PV and ET?
I think this clearly does help to identify individuals that have a higher risk of vascular events, and I think likely have a higher risk of disease progression over time. So just as I showed you that prognostic score from Professor Teferi with the PV risk score, higher leukocytosis does separate out a higher risk PV and ET.
Would it become an indication to start cytoreductive therapy?
I think it's at least a strong consideration. I find usually if they have leukocytosis, they probably have at least another indication for starting therapy anyway in terms of symptoms.
How do you manage polycythemia vera associated pruritus?
So I think, again, this is a common symptom. It can be a difficult one. It typically does benefit from cytoreduction. So the patient who has difficult pruritus, I think almost usually does need to be on cytoreduction. There are individuals who do benefit from hydroxyurea for their pruritus. There are interferon probably to a greater degree, and ruxolitinib is probably the most effective of all of the agents for pruritus. So if pruritus is severe, I will strongly consider ruxolitinib. Now, other agents that can help in complement, UV light, therapeutic UV light helps, although it still can be hard on the skin, but it clearly can help to provide relief. Antihistamines can help, although to a lesser degree. There certainly are some lifestyle things. Some individuals do find that if they air dry after bathing, that can sometimes lead to less pruritus than toweling off. So there are some lifestyle things as well.
Excellent. Duration of anticoagulation therapy for venous thrombosis in the case of polycythemia vera, for leg veins and for the portal vein.
It is a good question that we don't have an answer for because we've not really tested in a rigorous way the two approaches of stopping or not. I think the history is really quite important in this regard. So on the one hand, if the event occurred pre-diagnosis and now 6 months later, all of the other risks are controlled, the counts are controlled, and they're also on aspirin, phlebotomy, and cytoreduction, then you might be able to consider stopping the anticoagulation. If, however, the event occurred in the setting of controlled disease, then the comfort of stopping the additional anticoagulation, I think, is significantly less. Now, between these, we do not have proof that one of these is better than the other in terms of decreasing the risk of events. So I would, again, stratify based on the clinical situation in terms of expense, how well it's tolerated, but we don't have proof yet that the DOACs are better or that you need to do low molecular weight heparin.
Once you start them, you continue or you can stop them?
Again, I think it depends on the situation. If we clearly have reversed the factors and it was a lower risk event, so if it was a DVT at diagnosis and now everything is well controlled and it's a lower risk event like a DVT, then I may consider stopping it. If it is a higher risk event like a portal vein thrombosis, then I'm much more likely to keep it going. So I think it really depends on the severity of the event and really what is the difference between the time of diagnosis and now. How much additional protection have I really given them? If they had the event and already were on aspirin, their hematocrit was 42, and they were already on Hydrea. I'm much more concerned that I did not have adequate protection and would likely then proceed with keeping them on the anticoagulation.
And similarly, duration of antiplatelet therapy for arterial thrombosis.
Baseline status in terms of their lipids and how likely they are to benefit. With the second question, vascular events with small vessels, I think it's here really where the antiplatelet therapy is the most beneficial. I would point to, there was an article earlier this year in Blood, just earlier this summer, looking at giving twice daily aspirin at 81 milligrams a day. Twice a day is likely being superior to once a day in terms of its antiplatelet effects. And I believe in India you have the 100 milligram aspirin tablet, and I would probably extrapolate that it's a similar issue. That study was in ET, but it's probably a similar answer in PVERA. So I would consider an individual with these situations considering going to twice daily low dose aspirin.
Thank you, sir. If a patient of polycythemia vera has got a very high platelet count of 1.7 million, and there is no acquired von Willebrand disease, will you target this platelet count specifically and treat it?
I find that the majority of individuals that have counts in this range have symptoms that end up mandating therapy anyway. So it's difficult to know what isolated platelet count alone without von Willebrand or is worthy of treatment. And there clearly is a range of opinions amongst MPN specialists. But I find that it is unlikely that such an individual does not have symptomatic difficulties with the disease and probably would benefit from being on cytoreductive therapy.
Will you use drug like Yanamandra in this situation?
No, I would still go after their MPN therapy. So again, Hydrea or interferon as a start with ruxolitinib as a backup therapy. I will find sometimes these individuals do need a combination of two drugs to adequately control their counts if they are that high.
About JAK2 exon 12 mutated polycythemia vera. How common is it? How do one make a diagnosis, prognosis, and treatment?
So it's certainly quite a bit less prevalent than V617F. It's not common. It's certainly probably 5% or less. They do tend to present with higher degrees of erythrocytosis. So I'm most suspicious of it in individuals that the hematocrit is 60 or above at the time of diagnosis. Typically we will find it because we have reflex testing. So in the individual that is negative for V617F, our labs will typically then automatically run the exon 12. But if your assay, if that's not the case, I would clearly do it in individuals that you suspect PV that are V617F negative. Their prognosis, they may progress less often toward myelofibrosis. Treatment, I would probably still treat them the same way that we do treat patients that are V617F mutated.
And this mutation can be done from peripheral blood. You don't have to do marrow for this, right?
That is correct.
You have mentioned about COVID-19. Anything else you want to add about COVID-19 and MPN?
So we clearly are concerned about a higher risk of vascular events. It's difficult to still know whether the MPN patients clearly have vascular events at a higher rate than other COVID-infected patients. They certainly have them at least the same rate. I think in COVID-infected patients, I do consider this starting low molecular weight heparin for these individuals. Clearly, in hospitalized patients, we absolutely are anticoagulating everyone that is hospitalized. In an MPN patient, I will certainly, I have used it in some, depending upon their vascular risk. Have they had events before? How well is their disease controlled, etc., because of the risk of thrombosis and COVID if they develop that combination.
Well, sir, that was the last question. I'm amazed by the patience with which you have answered each and every question to the full satisfaction of everyone. And fantastic, that speaks volumes about you as a person, you as a scientist, you as a doctor. Thank you so much, sir, for sparing your 2.5 hours this morning for you and evening for us.
Oh, wonderful, wonderful. Well, it was an honor being here. It was lovely seeing you again, my friend. I hope we are able to see each other again in the future soon. Dr. Uday, it was wonderful having the podium along with yourself. Congratulations on well managing that difficult case, and certainly wish you all the best.
Thank you, sir. Almost 500 people have logged in today. Thank you.
Wonderful. Will you folks take care? Know that we're thinking of you here in the U.S. and hope that we will all find ourselves with the pandemic behind us in the near future.
Thank you, sir. Good night.
Bye-bye.
Bye, sir.